Hello everyone, my name is Sami Nassif and I'm a current fourth-year Otolaryngology resident at Tufts Medical Center. Thank you for showing some interest in our residency program and welcome to our 2020 virtual sub-internship experience. Due to some technical difficulties, this video will start at about the 10-minute mark of the meeting. Fortunately for everybody, you will not miss any of the content from the first 10 minutes as this is repeated in subsequent sections of the meeting today. If you have any questions, you can always feel free to contact us through our website and email our program coordinator. Thank you again for your interest, and we hope to read all of your applications during the 2020-2021 cycle. Thank you.
Education. People are hungry to get in on the next case, to see the unusual pathology, always hungry to learn more. We are committed to a diverse and inclusive program, and this reflects a commitment on the part of our National Academy. As you can see here on this slide, the new logo for our National Academy is We Are One, and we're looking for diversity, as I said, in all senses of the word, gender, racial, geographic background, educational background, prior work, life, and family experience. We are involved as a department in multiple outreach efforts to improve the pipeline into our specialty and into our department, reaching out to the level of high school students as well as undergraduates and medical students through mentoring, shadowing programs, panel discussions, etc. Through concerted efforts, we have made strides in the proportion of women and underrepresented minorities in our residency program. We are small, so the numbers can change a fair amount year to year. Currently, our resident complement is 70% women and 20% underrepresented minorities. So we are very lucky to have Dr. Joyce Saki, who is gracious enough to participate in our program today through a pre-recorded session. You can see her credentials here, which I mentioned in the recording as well. We are very fortunate to have a long-standing relationship between her and our department in promoting diversity and inclusion efforts in our department. I would like to introduce Dr. Joyce Saki, who is the Dr. Jane Murphy Gaughan Professor at the Tufts University School of Medicine, the Dean for Multicultural Affairs and Global Health, and the Associate Provost and Chief Diversity Officer for the Health Sciences Schools. Dr. Saki will be taking a few minutes to speak to us about diversity and inclusion efforts at the Tufts Medical Center and Tufts University School of Medicine. Thank you, Joyce.
Thank you, Dr. O'Leary. I am glad to speak to this very important issue. I know that both the Tufts University School of Medicine as well as Tufts Medical Center share the commitment to diversity, inclusion, and equity. And I know that the Department of Otolaryngology in particular has a commitment to attracting candidates from underrepresented in medicine groups to the residency program. And I want to start off by applauding your efforts for ensuring that there is diversity in the residency program. I know that there's been significant gains made over the last 7 years with regard to gender mix. It's quite impressive. I'm sure you'll be sharing those. And I know that you've made targeted efforts as well to ensure that there is a racial and ethnic representation in the program. I can speak to the fact that this Department of Otolaryngology has been an incredible partner to the medical school, both in terms of its ability to really provide capacity for pre-medical students, even sometimes high school students, to have experiences there so they can be exposed to the potential of going into medicine. But especially the fact that the chair of the department, Dr. Ali Rabiz, and I have had a long-standing relationship about mentoring. And I know that you not only mentor your residents, but you also have a propensity to really say yes to every time I call on you to mentor students at all levels in our pipeline programs. And so I think that I would want to make sure that any prospective medical students who's considering their residency program in otolaryngology, you ought to at least interrogate and see whether the program is committed to mentorship. Because if they are, then that means that you're going to be getting the mentoring that you need as you develop as a physician yourself. And this is a department that has demonstrated that commitment. And so in addition to the commitments to diversity, both gender, equity, racial and ethnic mix, as well as a commitment to mentorship, I know that this is also a department that is deeply committed to working and doing its part to address health inequities. And I can say that personally because I know over the years, Dr. Ruiz has been directly involved in extending access to care to underserved communities and individuals. And so I think this is a combination that really, I hope, especially to our underrepresented in medicine medical students, that this will really speak to your interests as well. And then I want to just say a couple of words about the medical schools efforts. We this year declared that we want to work towards becoming an anti-racist medical school. And that, what that means is that we are going to examine every aspect of the medical school's policies, practices, and processes to ensure that we are anti-racist, both in our intent, but also in our impact and the outcomes of the things that we do. This means that we're going to be recommitted to increasing representation or compositional diversity, as we like to describe it, as well as making efforts to have initiatives that ensure that when students and trainees join us, and in fact faculty and staff as well, when they join us, that they have a sense of the community here at Tufts, and that they have a sense of belonging. It is our medical school has worked very tightly with Tufts Medical Center, and many of the initiatives that I've described and the ones that we'll be launching as part of this renewed commitment to becoming an anti-racist institution will in fact include major teaching hospitals such as Tufts Medical Center. So not only would a prospective candidate applying to otolaryngology have that community at Tufts Medical Center, but you also can count on a sense of community that includes the entirety of the university and especially the medicals. And so with that, I'm going to turn things over to Dr. O'Leary.
I was muted there. Thank you very much, Dr. Saki, for your words. We appreciate your taking the time to speak to medical students through our virtual seminar today. Thank you.
You're welcome. Thank you. My pleasure.
All right. So thank you, everybody. This was our first session. We're going to wait till 12:30 to begin our next session, which will be Meet the Residents at Tufts Medical Center.
And of course, if anybody has any questions in the next few minutes, you can put them in the chat box, or just go ahead and ask. You can unmute yourself and speak up.
the different sites is most time spent at Tufts Medical Center. And
Well, yeah, I suppose, are you guys going to touch upon that during the presentations?
yes, we'll definitely go over that breakdown.
Okay.
All right, so here we have Rebecca Compton, our PGY5 chief at Tufts Medical Center. She's gonna start a presentation on who are the residents and our schedule, and then Jennifer Harb, our chief at Rhode Island Hospital, will continue the presentation afterwards.
All right, that sounds good. 1 second. Hello, everyone. My name is Rebecca Compton, and I'm joined by my co-chief, Jenny Harb, today. And we just want to give you an overview of the resident life in our program. Boston's a great city. We're a great program. We have a lot of fun, so we hope that this comes across today. So we are a complement of 10 residents, 2 in each class. There's no fellows in our program, so it's just us. And we're incredibly close, and by the end of this, come to feel like family. Our current complement includes myself. I'm from Western Mass originally, and I'm planning to do a fellowship in pediatric ENT. My co-chief, Jenny, she's from Buffalo, New York, and she's planning to do a fellowship in reconstructive plastics. Michelle is one of our PGY4s. She was born in Canada and grew up in Pennsylvania. She's also planning to do a fellowship in pediatric ENT. And Sammy is another PGY4. He's from Columbia originally and planning to apply for fellowship in head and neck. Tanya is from LA and is undecided about her future interests. Chris is from Cincinnati, Ohio, and planning to do fellowship in facial plastics. Moving on to the PGY2s, Emily is from North Carolina originally and may have some interest in neuro-otology. And Ramya is from Toronto and then New York, and she may have some interest in laryngology. And then finally, our 2 interns, Peter is from Washington, D.C. and is undecided about the future. And Bella is also from that area and may have interest in peds or plastics. So we come from all over the country and even other parts of the world. We're a diverse group, but we get along very well. And like I said, it's a very tight-knit program. So as was mentioned, about half of our graduates pursue fellowship and the other half pursue jobs in private practice. I would say we receive support to go in either direction. Our attendings are happy to help us in any way that they can. And we've had good luck with the fellowship match and with finding jobs. You can just take a quick look at some of the places where past graduates have gone. Just briefly, we'll go over where we spend our time on rotation. We have 4 different rotation sites in this program, and we'll have a chance to talk individually about each of them, so I won't get into too much detail. About 50% of time in residency is spent at Tufts. That's considered the home base. And then the other 50% of time is split between Boston Children's Hospital, which is a dedicated pediatrics rotation, Rhode Island Hospital in Providence, Rhode Island, which is a busy level 1 trauma center, and then the ENT specialists private practice group in Brockton, Mass. And all these sites are within driving distance of each other. So the rotation schedule at Tufts, it's 5 years. In the first year, the intern spends about 6 months on ENT and 6 months on general surgery. The ENT bracket of rotations includes 4 months at Tufts, 1 month at Rhode Island Hospital, and then 1 month rotating with the oral surgeons, which is a fun experience. On general surgery, we try to arrange rotations that are most relevant to our field. So interns usually spend time in the surgical ICU, on neurosurgery, on surgical oncology, thoracic surgery, have to do the obligatory night float month, and then get 1 month at a community hospital. PGY2 consists of 2-month rotations. There are 3 at Tufts and 3 at Rhode Island Hospital, which provide kind of complementary experiences and break up the year nicely. In PGY3 year, the rotations are 3 months long, and they include 6 months, so 2 3-month rotations at Tufts, a 3-month rotation at Boston Children's Hospital, which you'll hear more about later today, and then a dedicated 3-month research block, which just has some limited call responsibilities, otherwise is totally dedicated to research. PGY 4-year also consists of 3-month rotations. Again, let's just say 6 months at Tufts, 3 months at Rhode Island Hospital, and 3 months with the Brockton Private Practice Group. And finally, PGY 5 is sort of a similar structure, 6 months at Tufts, 3 months at Rhode Island Hospital, and 3 months in Brockton. The call schedule is something you should know about. In general, I would describe this as a home call program. There's a little bit of variability depending on the rotation. Tufts is definitely home call. We have 3 different call teams, well, sort of 4 actually, and split up the weekdays and weekends accordingly. You typically go home at the end of the day, carry your pager, and then if something comes up, you come back in, and then typically go to work the next day. The trauma call is shared with oral surgery, so we're on call 1 month at a time, and then it switches to oral surgery and back to us. And yeah, the call is distributed equally among the different call teams, so it's not really too burdensome. Rhode Island Hospital is described as a home away from home call. We have an apartment near the Brown University campus down there, so when we're on call, we stay at that apartment, but we don't have to stay in the hospital, which is nice. This call is split between the PGY2 and PGY5 resident, as well as a PA call team. And it ends up being usually 1 day a week and then every other weekend. And we cover trauma during the week and then just on 1 Saturday a month down there. Boston Children's Hospital, that's the only in-house call experience that we have in residency. It's in-house Q3 call, split among residents from across the city, and you'll hear more about that. And then the ENT specialist practice in Brockton, the private practice rotation, that one is home call, and we just cover kind of limited weekday and weekend calls from home. So that's that. I'll turn it over to Jenny now to talk to you a little bit about research, didactics, and life in Boston.
Hi, everyone. I'm Becky's co-resident of another PGY5. And everyone can hear me okay. Did we lose our slides, I think?
Oh, do you want me to, I stopped sharing, but I can put it back on.
Could you?
Sorry
and
that.
then I guess I'll just have you press the next slides for me, if you don't mind. Thank you. Next slide, Becky.
There we go.
Okay, great. So I'm going to talk a little bit more about the research aspect of our program. So as Becky mentioned, we do have 3 months that are dedicated as a PGY3. There are numerous opportunities available clinically, if that's what you're interested in, or bench opportunities. We do frequently collaborate with some of the other institutions around Boston. It's pretty easy to get in touch, and we make friends and good contacts with lots of those other attendings and researchers. So it just sort of depends on what you're interested in. Almost at every, we can keep there. Almost at every, go back to the other one, sorry, Becky. So, at every major national meeting, pretty much at least one of us is at least presenting a poster, we have a presentation. We're pretty well represented at most of the major conferences. That would include, the Academy, COSM, TRIO, ASPO, head and neck, AFPRS, which is the plastic surgery, reconstructive surgery conference. And so we're pretty active in research. We do have a general, Dr. O'Leary may have touched upon this, we do have a requirement to try to publish at least one research paper or presentation per year. But if we could go on to the next slide. This only partially represents what we've accomplished recently. So, I mean, you can see we have lots of publications, lots of posters and presentations. The presentations are kind of mixed in with the posters in there too. But we are very active in research, and many of us have numerous projects that are ongoing simultaneously and with other institutions, as well as within our own and with medical students that are interested. So we can move on to the next.
Yeah, it took size 3 font to fit everything in the last 2 years. So
and that's not even everything. I received additional papers from Michelle last night that didn't actually make it into this PowerPoint. So we have, there's a lot of research going on. We also are fortunate to have received some grants for some of our research as well. So Becky and I and Dr. O'Leary actually have a grant for tracheostomy management for the non-otolaryngologists, in which we, it's been kind of sidelined due to COVID, but prior to that, we would go and discuss proper tracheostomy management with other services within the hospital. We also have a couple spin-off research projects based off of that, and we were lucky enough to receive a grant to do that. Becky also received a resident research award for her work with neuroimmune mediators for nasal polyposis, a prestigious award. And we also have just been fortunate enough to receive numerous travel grants to attend various conferences around the country. Again, I'm not sure if this was already mentioned by Dr. O'Leary, but we do have support from our department to attend various conferences, especially if we're presenting. You know, we do make it a priority to have the chiefs every year attend the academy meetings. This is important for networking and, you know, being up on the latest research. But, you know, if you have any presentation that you're giving, any poster that's accepted, the department does provide resources, financial resources for you to attend that conference. So it's not out of pocket. So that's very nice as well. I guess next slide. Thank you. So now we'll move on to our general weekly didactic schedule. And this is pretty constant from week to week with very small changes as needed. But basically our major didactics day is Wednesday. So we start off the normal day by rounding. And sometimes in the morning from 7 to 7:30, we'll either do what we call kind of like attending rounds or walking rounds, where, if there's an interesting or particularly involved case, we'll, have a kind of a round table where we, discuss that patient in detail, go over the imaging, pathology, what's been done for that patient. So it's kind of a nice teaching session in the morning. Or we do a chalk talk where one of the members of our team, or if a medical student or semi is rotating on our service, usually they'll give a 15-minute chalk talk about something that, we saw during the previous week, or just a question that arose. After that, from 7:30 to 8:30, and this is a pretty constant thing as well, the PGY4 will do a mock oral board review with the attending who is on call that week. So we'll, they'll basically present a case to us, and we just have to act as if this is the actual oral board exam, ask the questions that we would ask, and they go through imaging and pathology. And so that's a really good teaching experience to kind of be put on the spot and ask questions and see how you respond in the moment. Then 8 to 9, we have a head and neck radiology conference that we do with the neuroradiologists, and we go through and just discuss any interesting scans. After that, we have a little bit of break in which we do clinic, or if there's ORs going, we'll go do those. And then the afternoon, we're back to didactics. So 1 to 2 p.m. is generally head and neck tumor board that the senior residents generally attend. Or if you're a junior resident, there's audiology lectures, and those persist throughout the year. So we get a very robust education in otolaryngology, of course, and audiology and SLP, which is speech and language pathology. From 2:30 to 3:30, this one sort of varies a little bit from week to week. Sometimes we try to do a chapter review, or we'll go through questions from our board questions, and so we'll go through them as a group and discuss the different options. Additionally, from 4 to 6, we have our weekly didactics that we split with, or we join with the Boston Medical Center group. So basically the way that generally works is we will do half of the lectures, they'll do the other half, and we do the lectures as a group. So we see them every week, which is a nice thing because we get to know them pretty well, and they end up being our friends. So that's nice. Thursday, we have a late OR start. So we generally use that hour in the morning to do various educational things. So if it's a guideline review or a journal club or, you know, just discussing another topic, that's another opportunity to do that. And then Friday, we have every other week is a late OR start, meaning it starts at 8:30 instead of 7:30. So that's another opportunity. And then every resident, with the exception of the PGY ones, does a M&M, does a grand rounds presentation throughout the year. And so that's a 1 hour long presentation on a topic of your choosing that you give to the department, and, you know, people can ask questions, and generally well received. And then we also have something called NEOS, which is the Northeastern Otolaryngological Society, where basically the PGY3s will give their a 15-minute talk about a topic, again, of their choosing, but that kind of goes along with the topic of that NEOS. Actually, I think go to the next slide, because we may touch upon, there's another, oh yeah, here we go. So with NEOS, you know, so basically NEOS is a meeting that happens 3 times per year, in which most of the residencies in the Northeast will join up, and we'll go through a day of various speakers and just kind of activities. And so generally the people that come are us, Boston Medical Center, Dartmouth, Mass Eye and Ear, Albany, UConn, University of Vermont, and Yale. And so the PGY3 Samar department and a speaker from all the other participants as well will give a 15-minute presentation, and then at the end, it's voted on and somebody ends up winning. And we've actually been pretty successful in terms of placing at these competitions. And there is a cash prize, which is kind of nice. So yeah, it's kind of a fun experience. And we do a lot of practice with our own department prior to these presentations. So we're ready to show our stuff in front of everybody else. And if we could go back to that other slide that I think we skipped. Great. Yeah. And so also, you know, there's a lot of programs in the Boston area. So there's Mass Eye and Ear, there's BMC, there's us. And so we, you know, it's not a sort of environment where we're in competition with everybody else. We really do sort of work together, and we do a lot of our didactics together. So I just talked to you about NEOS, and that's us, and, you know, lots of other programs in the area. But, you know, we also have the Wednesday afternoon didactics with BMC. We have a crash course that we also do with the Boston Medical Center residents, which is basically an intensive 1-week course for the incoming PGY2s, where they kind of learn how to do the basics of everything that they're going to be, you know, seeing in various situations. We also have gross anatomy and temporal bone courses that we will do with Mass Eye and Ear as well as BMC. We have a CORS course, which is like a children's ENT course that we do at Boston Children's, and that's again with Mass Eye and Ear and BMC. We have a sinus course where we go through sinus anatomy and a gross kind of gross anatomy and doing procedures on cadavers. That's also with Mass Eye and Ear and BMC. NEOS we talked about. MSO has you know, Massachusetts-wide meetings that we will try to attend as well. There's also a kind of a fun conference called the Scary Cases Conference, where you know, again, people from the Boston area will present a scary case that they witnessed in the past year or so, and it's very interesting, and I'll show you one later in our Rhode Island presentation. And then we also have the Boston Thyroid Club, which is another meeting that, you know, discusses thyroid issues, and again, that's an interdisciplinary, multi department sort of meeting as well. And we can go on to the next. Okay. Our program, I think, is unique in a couple of ways, and so we'll just run through that quickly as well. So most programs will probably have some sort of ICU rotation. In terms of hours, we do a month in the surgical ICU, which is a really good experience. And this is done as an intern. As an intern, you're taking call, you know, pretty independently in the SICU, overnight during the day. We have a PGY2 general surgery resident who's kind of leading the way, but you get to do a lot in that rotation. You learn a lot about ventilator management, lines, taking care of critically ill patients. We also, and this is a great part of our program too, we have a cleft lip and palate team. So in the hospital, the ENT service does the cleft lips and palates. In some other hospitals, you may find that it's kind of split or done exclusively by plastics. But at Tufts, we do all of those procedures. And so we have a multidisciplinary, interdisciplinary cleft palate team and cleft lip team that goes through all of the different things that these children end up needing, dental, oral surgery, audiology, SLP, ENT, and it's a very good experience and nice to have that sort of exposure as well. We have a pediatric voice clinic, a multidisciplinary pediatric aerodigestive clinic. We have hypoglossal nerve implantation, which Becky, do you talk about a little bit more later?
Yes.
Okay, so I won't go over that too much. As you can see with all of our meetings and all the time that we spend with the other programs, we do have a good collegiality with these other programs. And like I said, it is not meant to be a competitive or malicious sort of relationship with any of these programs. It's nice to become friends with these people and meet everyone and exchange ideas. And it's been a good experience. We also have mission trip opportunities. In this photo here, you can see some of our recently graduated residents, Zach and Aaron. They did a mission trip together to Rwanda, where they take out these massive goiters with one of our attendings, Dr. Dingra, and that's an awesome experience. I'm hopefully, if it doesn't get canceled, I'm hopefully supposed to go to the Philippines to do a cleft lip and palate trip with another one of our attendings in our program too. So those opportunities are available, and they're encouraged for you to go on. Another unique thing about our program is we have a private practice experience, and that's our Brockton rotation, which you'll hear a lot more about, so I won't go too much into that. Rhode Island and Tufts, again, two very different experiences. You'll hear more about that later. And we're a small program and hospital, and I think that's important to emphasize because that means that we get to know our other departments very, very well. We're on first name basis. These are our friends. You can see in these pictures here over to the side with Sammy, who's, I don't know if you can see my pointer, but right here, but we have a lot of the oral surgeons here, an anesthesia person, and a member. These are just the people we hang out with and know and spend our time with, and you become very, very close with these other departments. So it's nice to kind of have that sort of relationship with everybody, and that's what you get kind of being in a smaller hospital. We can go to the next if there's anything more. Oh, and then yeah, life in Boston. It's great. So, there's a lot of historical things in Boston, the Freedom Trail, lots of museums, there's great dining. The bars, nightlife, breweries, that sort of come to a little bit of a halt at the moment, but they exist, and maybe at some point they'll be reopened. Tons of colleges in this area. So, there's a lot of college students, which some are mostly maybe in the Fenway area, I would say, but, still exists. We can go to the next slide. We have some sports teams that you may have heard of as well. And we do try to go to various sports games together. There is an MSO, the Massachusetts Society of Otolaryngology event, where they try to get us all together at a baseball game. They get this little area off to the side where there's food and drinks, and we can mingle with ourselves, our attendings, as well as the Mass Ioneer and BMC people. So that's really nice as well. Next slide, please. Thank you. And then Massachusetts, it's centrally located in the midst of lots and lots of really cool places. So, we're about an hour from Providence, and that's where I am right now. And Providence is a lot of great food, a lot of just beautiful areas to explore. 2 hours from there is New York City, so it's a quick drive away, 2 to 3 hours. So you can see it down there. If you want to go a little bit further, there's, across the pond, some easy direct flights from Boston or from Providence to Portugal, if that's what you're into. And yeah, medical college town, kind of covered that. we can move on to this. Where to live? Lots of different areas that you could live. Lots of us live like right by Tufts in the Chinatown area, or South End, Back Bay. Some of us live in South E, which is different from South End, or Seaport. And I think the next slide might show some of the areas that we live. Yeah, so we're kind of scattered everywhere. Some people have lived in Cambridge in the past. But basically, the goal is to live within about 20 minutes of the hospital in case you do need to come in sort of emergently. So you have a wide area of places with a bunch of different sort of price points where you can live. And next, where we go, and this again will be covered a little bit more in detail. Yeah, so we'll move on. And then we do lots of things as a group together. Here's just some of the things that we do. This is us at a beer garden. We're doing an escape room. We have fun like we do. We try to meet up outside of the hospital as well. And the GME actually supports us in that in terms of helping us. They actually financially fund a get together for us, which is nice. And we can move on. Yeah, just some photos of us together. So yeah, basically what we wanted to get across is that we're a small, friendly residency program. We work well with other specialties in the hospital and, in the general vicinity of Boston. Our attendings are very, very supportive and helpful. We have a lot of one-to-one contact with them. We get exposure to all the areas of otolaryngology, which is important. And we have a lot of research opportunities. A lot of us are engaged in lots and lots of research. We do lots of fun things. And I think all of us are very happy with, being in Boston and the areas that are nearby.
Great. Dr. Beach just asked me to bring up a photo of, what's my favorite event of the year?
Oh,
the annual golf tournament. Citywide, the BU, Mass Pioneer, and Tufts programs come together to play in a golf scramble. It's always a good time. We usually have a good turnout. Some people play well, others don't, but it doesn't matter. It's a scramble. So anyways, just wanted to show you that we get along well in the city, and it's a tight-knit ENT community as well.
Reggie, can you share that picture on the screen? See if it pops open?
Oh, it's not showing. Oh, hang on.
Well, we keep looking for the picture just to remind students that we are going to start our next session at 1 o'clock.
I'm sharing it. Can you guys see it?
Yes, we can see it.
So that's the group. I might join this year. We'll see. This year it was postponed from June till September, so we're keeping our fingers crossed.
Does anyone have any questions? You can put them in the chat or just speak up.
Thank you so much for doing that. I just had a question about the mission trips.
Sure.
Can you just talk a little bit more about the opportunity, when it is, where, like what type of work that includes? Thank you.
Yeah, and I think there's a couple of attendings on here too that might be able to speak toward that a little bit. So I'll just give a brief rundown. So Dr. Dingra is one of our Brockton attendings, and he does an annual trip to Rwanda to take out these massive goiters. There might be some photos later. It's been a great experience for the people that have been able to go to that. It's a week-long time, and it really helps the people that are able to undergo those surgeries, because it's a major social stigma to have this massive mass in your neck. So that's one of the opportunities. I am hopefully going on one to the Philippines, which I briefly mentioned, and that's primarily to do cleft lip and palate work. And that's with Dr. Snyder, who runs medical missions for children, and so that's another opportunity. We also, Dr. Marston and I was supposed to also go, but it got canceled because of COVID. But there's another organization called Global Smile that sometimes we work with, and they also do a lot of cleft lip, palate, some microtia work as well. And I don't know if any of the other attendings on the line wanted to jump in with any further details.
Sure. Hi, it's Dr. Scott. So I'm sure this has already been said. I just hopped on now. I'm at my parents' house, so forgive the elderly decor around. So essentially, we have a fund that will pay for offset a lot of the costs for any international travel related to research or humanitarian work. And so if a resident finds like an organization or something that they're particularly passionate about and they want to do, then we will look at that, examine that, make sure that all parties have vetted it, and we think it's going to be a good, worthwhile experience. Nobody's just going to go there on their vacation time and be told to take pictures while others are operating or something like that. We definitely have a preference to have the resident go on a trip where there's a faculty member as well, and as was just said by Jenny, there's lots of opportunities for that between goiter, cleft, microtia, and there's at least 4 of us that are doing that actively attending wise. So there's lots of different opportunities. We often have the residents apply for an academy grant, but whether you get it or not, that you're being able to go on this trip does not hang in the balance the way that does it in a lot of other programs. To my knowledge, there are not many residency programs out there. There might just be 3 now, maybe 2, that actually have built-in funding for residents to do humanitarian work. Otherwise, you just have to come up with that cash on your own. So it's something we're proud of, and it's something that we want to enable the residents to do.
Thank you.
All right, so with that, right on time, let's start with the little overview of the Tufts Medical Center site. We're going to start with Becky Compton as our chief there. She's going to give a little overview, and then we'll hear from Dr. Tracy and Dr. Scott. Go ahead, Becky.
All right, sounds good. Everyone can see the slides okay?
Yes.
All right, so my name is Becky. I'm the current chief at Tufts, one of 2 chief residents. Jenny and I will switch in 3 months. Just hoping to introduce you to the rotation at Tufts Medical Center. 1 second. So today I'll give a brief overview, and then we have Dr. Scott, who is a pediatric ENT and has been on faculty for a while and completed residency at Mass Eye and Ear, pretty nearby. And then Dr. Tracy, who completed our program in 2014 and just joined as faculty. So Tufts Medical Center is a 415-bed small academic medical center, but it includes everything. It has an adult hospital as well as an on-site pediatric hospital called the Floating Hospital for Children. It's a level 1 trauma center. We get referrals from all over the state as well as neighboring states, New Hampshire, Rhode Island, and Maine. We take care of a diverse patient population, and the hospital has all sorts of residency and fellowship programs. Our program, however, is just residents. The rotation structure at Tufts, so you spend 50% of your time in residency at TMC. It's our home base. Typically, the team includes a delegate from each class. So we usually have a PGY1, PGY2, 3, 4, and 5. And in each of those years, you spend about half of your time at Tufts. Our program leadership is very strong and very stable. Dr. Ruiz has been the chairman since 2002, and Dr. O'Leary has been the program director since 2012. And they both do everything in their power to help their residents succeed. We have very good representation in all the different subspecialties. Dr. O'Leary is our chief of head and neck surgery, and she's joined by Dr. Tracy in taking care of both the ablative and reconstructive aspects of head and neck cancer. Dr. Ween, who is also a fellowship trained head and neck surgeon, he's moved his practice down to Rhode Island, so you'll hear more about that in a minute, but he's maintained his affiliation with Tufts in order to do sleep surgery. He was the first surgeon in Massachusetts to perform the hypoglossal nerve stimulator implant, and he's done 86 of these at this point. So he sees patients both in the clinic and in the OR on Fridays, primarily to deal with sleep surgery. We have 3 fellowship-trained pediatric otolaryngologists, Dr. Vecchiotti, who is the chief of the division and treats most aspects of the subspecialty. Dr. Scott runs the cleft lip and palate team and has a special interest in craniofacial surgery. And then Dr. Marston, who just joined last year and seems excited about all aspects of the subspecialty. Facial plastics and reconstructive surgery is especially strong. This is directed by Dr. Lee, who was also one of our residents and has a very busy functional and cosmetic rhinoplasty practice and sees patients for aging face concerns as well as post-Mohs reconstruction. Dr. Marston also completed a fellowship in facial plastics, so he's dual trained, and he has a special interest in facial nerve reanimation as well as many other aspects of this area. And then I would just mention that a couple other of our doctors, Dr. O'Leary, Scott, and Tracy, incorporate aspects of facial plastics and reconstructive surgery into their practice. So we do get a lot of experience with this. Dr. Rabiz is the rhinologist for the program, and he treats all sorts of conditions, chronic sinusitis, polyps, sinonasal malignancy. He works closely with Dr. Heilman from neurosurgery on the anterior skull base work, and we do roughly 25 joint anterior skull base procedures per year, pituitary adenomas and that sort of thing. We have 2 neurotologists, Dr. Silman and Dr. Noonan, and they happily treat all aspects of the field, chronic ear, hearing loss, cochlear implants, etc. But they maintain an active lateral skull base program with Dr. Heilman and do roughly 25 skull base tumors per year as well. So we get very good exposure to that. In terms of laryngology, Dr. Roan joins us part-time. She's a fellowship-trained laryngologist who works part-time at MGH and part-time at Tufts, covering all aspects of adult laryngology. And then Dr. Vecchiotti runs a pediatric voice clinic. So I think we have, very good exposure to all areas of the field. We were hoping you could join us in person. It would have been great, but you can't for obvious reasons. So we just wanted to take you on a tour right now of what we've been up to lately. So in terms of head and neck cancer, we've done a couple of total laryngectomies, neck dissections, sort of basic head and neck procedures. We had a partial glossectomy that was reconstructed with a radial forearm flap recently, and here you can see a kind of neat picture. The flap incorporated a tattoo design.
Did you do the tattoo before or after the flap inset?
I think
on that case.
It was long before.
It's important to orient the tattoo in the future so that you really can get the most out of it once it's been transposed. I find that, at least in children, that there's much more parental satisfaction, just for teaching points.
Yeah.
And we had a case of a young man who presented, but it was actually a benign mandibular tumor that we resected. It left a large mandible and intraoral defect that we used a fibula flap to reconstruct. This is just a kind of cool picture of some intra-op fluorescence, hopefully this plays, using the SPY system to detect perfusion of the skin paddle of the flap. Let's show you a couple seconds of this. In the flap was perfused. Here is a snapshot of Dr. Tracy using the robot to perform a radical tonsillectomy. He's really looking forward to building the robot program at Tufts, so we can't wait to see more of this.
In pediatrics, we'll also show you how to remove those without the robot.
Yeah, there's also plenty of the basics. As I mentioned, Dr. Ween has really grown the sleep surgery program. He's done 86 hypoglossal implants. These involve a respiratory sensor that triggers a pulse generator, which sends a mild stimulation to the hypoglossal nerve, and this maintains airway patency, which you can see right here. Pretty cool. And then our pediatric ENTs have been very busy. Recently, we repaired a case of coronal craniosynostosis, which is a premature fusion of the coronal sutures. I think that this video explains it
Late
well.
repair of unicoronal craniosynostosis using virtual surgical planning technology. An 11-year-old girl presented with right forehead swelling and brow asymmetry. The radiographic image is of a younger patient with the same deformity. The diagnosis of unicoronal craniosynostosis was made. A virtual surgical planning session using the patient's CT data determined an optimal approach to reconstruction with minimal bone loss. A customized cutting guide was created to assure precise placement of the craniotomy and subsequent osteotomies. The procedure began with a bicoronal incision to expose the frontal bone and supraorbital rims. The cutting guide was placed and markings were made accordingly. These corresponded with the markings in a three-dimensional model supplied with the simulation package. The neurosurgeon made burr holes and the frontal bone was removed. The otolaryngology team performed the remainder of the case. The supraorbital bar was removed using the piezoelectric device to minimize bone loss. The inferior aspect of the frontal sinus was exposed. On the back table, the extent of the orbital deformity and forehead asymmetry is appreciated. The frontal mucosa was also exonerated from the bone flap. The piezoelectric device was then used to make precise cuts. The guide was provided to demonstrate proper repositioning of the bone pieces. The inner surface of the calvarium was thinned to allow green sticking of the bone fragments, flattening or bending them as necessary. The orbital repositioning guide demonstrates the degree of advancement required. The inner cortex of the orbital rim was thinned until the bone could be bent into proper configuration. This was reinforced with resorbable plates affixed to the inner surface of the orbital and frontal bones. The complete forehead and brow reconstruction is demonstrated on the back table, resembling the computer simulation. The fronto-orbital complex was then placed back into the anatomic position and secured to the skull, with large gaps filled with bone trimmings. At 3 weeks post-operatively, there is improved symmetry of the forehead and orbits. The child, who has an astigmatism, is now able to wear glasses, and she no longer is self-conscious about her appearance.
Were you trying to get crazy with this?
So we also took on a challenging airway last week, a young boy with congenitally narrowed airway from vocal fold paralysis and subglottic stenosis. We were able to repair this endoscopically by splitting his posterior cricoid cartilage and inserting a rib cartilage graft.
Cool.
Those are the vocal cords that are spread apart. And here Dr. Scott is inserting a posterior graft. Et voila.
No Cypress Hill on that one.
Haven't edited yet. Actually, that was Guns N' Roses' Patience was playing in the background, which is very good because those things usually take a long time. So
Yeah, I was gonna say it always goes just that smoothly when you do those endoscopically. I understand.
Well, hey, I wouldn't know. It was definitely a read one, do one. So that's how it goes.
So septal perforation is a tricky problem for most otolaryngologists. It's not a very popular case. Dr. Marston recently took one on. You can see a large perf over to the side of the screen here. He used an absorbable PDS plate that he covered with temporalis fascia and was able to insert that into the perforation to provide a scaffold for remucosalization. So we're looking forward to seeing the results of this. We've also had a number of really good trauma cases, mandible, midface, open, closed approaches. And we also had an interesting case of a CSF leak. A patient presented leaking CSF, cerebrospinal fluid from the ear. This was kind of cool. We detected an area of dehiscent bone in the tegmen, which is a thin bony plate separating the middle cranial fossa from the middle ear. We were able to repair this by exposing the tegmen from below using a mastoidectomy, and then in the style of neurosurgery, performing a mini craniotomy to expose the tegmen from above, and then we could insert a little cartilage graft, which you can see right there. So with that, just wanted you guys to see we've been up to all sorts of cool things. There's also plenty of the basics, the bread and butter. You can get a really good operative experience here. I'll turn it over to Dr. Scott and Dr. Tracy to hear their unique insights into the program.
Thanks, Becky. That was great. Can you all hear me?
Yeah, we can hear you.
I've had some issues with that. I apologize. So I don't have a whole lot planned. I don't know if you do, Andrew, but I think one thing that I wanted to emphasize, and I think Becky did it with her presentation, is the complexity of the cases. That's something that I'm excited about coming back to Tufts. I worked at University of Massachusetts for the last 5 years, but so it's a smaller department in terms of number of people, but the referral pattern is such that you really take care of kind of interesting, complex challenges. And I think, you know, that's what a lot of us like to do as surgeons. So.
Yeah, I agree with that. I think that all of the interesting cases that one would see at any program, you will have exposure to at Tufts. What's very unique is that, you know, we won't have necessarily like, you know, 3 free flaps a week, but we will have more than enough free flaps and more than enough very high level fellowship cases, but not a single fellow to dilute the experience. So, you know, as someone who does cleft and craniofacial work, I had a craniosynostosis case this past Monday, which is, again, one of these things that most otolaryngology programs you just wouldn't have exposure to. That's political. It's not because any otolaryngologist couldn't learn very quickly to do that operation. But we don't have those political barriers or Tufts, which is really fun. And it's a fun place to train for that. So I had the PGY 2 or 3 with me that day. And, you know, that's an unbelievably end of fellowship level case if you're lucky, you know, having completed 6 years of plastic surgery residency and, you know, most of your craniofacial fellowship. So, and it's PGY 3 case afterthought at Tufts, which is great. So I do think that you guys will have lots of exposure to very high level cases without having the go-between of a fellow to swoop in at the last minute and steal the cochleostomy and things like that. So I think it's a great experience. I think it's something that as attendings we're very proud of. And we are a pretty small program for the amount of cases and complexity that's available. And so that's also a unique and satisfying part of it.
I would just add that in terms of the kind of breakdown between clinic and the OR, it's graduated throughout the years. So as PGY 5, I'm spending almost all my time in the OR, and it's a sort of similar situation. The PGY 4 spends 4 to 5 days. PGY 3, you know, 3-4 days. But even the PGY 1 and 2 are getting in a good amount. We have them split time between clinic and OR. So I think it's really a good operative experience early on, too.
Becky, would you comment on the new addition of the inpatient PA?
Oh, sure. Yep. Yeah, we added an inpatient PA, Kaylee, just new as of June. She's covering the inpatient pager and helping us with tasks like progress notes, discharges, inpatient concerns, discussions with case management. She's also helping out a little bit with consults, but those are mostly covered by the PGY 2 resident and the other residents on service. But it's been a tremendous help to have her. There's just so much she can do in a day that was difficult for us because we were trying to get to the OR or to clinic. So I think it gives us a chance to focus on the training. And she's fitting in very nicely with the team.
Good.
Thank you, Becky.
And I might add, you can meet Kaylee on our Instagram. She has a few nice pictures. Are you guys going to talk a little bit about the Instagram? Invite all the students to check it out.
Yeah, what's the handle?
I think that many of the students heard about this virtual sub-I via Instagram. So
Okay. I'm learning a lot about our program, our residents, and our PAs from the Instagram, by the way. So thank you for saying that.
Please check it out. Dr. Rabiz just provided the link. And we'll continue to update it as the summer goes along. There's many more people you can meet. We started with residents, but the program is much bigger than that.
And Alex, Dr. Marston, are you going to work on our TikTok channel, or what's going on there?
Yeah, I'm just waiting to see if it's outlawed or if Microsoft's going to step in and take over the American version of it.
Fair.
I do want to ask a question to Dr. Tracy, actually. You were a resident here. How has the residency improved since you were a resident, and what kind of brought you back here to Tufts?
Well, I think I can't decide. I wanted to come back to Tufts because all the things that you folks have highlighted in these talks, primarily it's the faculty. You know, everyone's really skilled at their craft and are really motivated and really driven to teach that. I think having worked at some other hospitals and trained at some other hospitals, you don't always see that commitment to teaching it. So that's kind of, I think, how I built relationships with the people at Tufts that have brought me back. And I think that how it's improved, I think, is easy is some of the new people they've brought on board. I mean, it's basically all the faculty that were there when I was there 6 years ago are still there. And now we have Dr. Noonan, who's another neurotologist, so even more volume, new, different, techniques. Dr. Marston, who's brought in kind of facial plastic side in terms of pediatrics and stuff. And I like to think now I'm bringing something to the table too. So kind of all the same great teaching that I had, plus some young new faces too.
Great, thank you. All right.
Any questions from any virtual sub-interns have any questions? Shouldn't we be pimping them if it's a sub-internship? No?
Again, if you have any questions, guys, please type them in the chat box, and we can answer them as we go or at the end of the session. We do have our next session at 1:25, so we have a couple minutes, either a break or people can...
Yeah, I want to say to all the students who joined us, don't be shy. Feel free to open up your cameras so we can get to see you, to meet you. Feel free. You don't have to if you don't want to, but we're not going to judge you if you're wearing a t-shirt today, if you're outdoor. It's a weekend, so feel free to unblind your camera, so we'll get to know, we'll meet you all.
Now, Ellie, is that a virtual background that you've got, though?
Ellie, that one book behind you, can you show me that? Pull that one out for me.
Yeah, pull that out.
Which one?
I just want to make sure,
Which one? Well, you can see it when you come to my house next time.
Okay.
Yeah.
Sounds good.
I wanted to say that we're thrilled to see folks from all over the country. We are not keeping track of who is here and not here. Your participation has no bearing on our selecting applicants for interviews. So just to clear the air on that, we are also recording this and hope to post it for folks who are not able to participate live today.
And we got to say it again, it's a Sunday. I know you're taking time away from your families to join us, so we really appreciate that. And we don't expect, everybody to be able to join, but thank you for doing that.
All right, we'll start at 1:25, the next session.
Thanks a lot, guys.
Thank you, Dr. Tracy.
So we just sit in awkward silence here for a little bit? Is that how this is going to go? That's cool.
Well, you can go ahead and get started, Jan. I mean, it's okay. Everybody's here. We're not expecting anybody else.
Get started.
Yeah, if we finish a couple of minutes earlier, I think everybody will be happy.
All right, so we're gonna do our Rhode Island rotation next. We're gonna have Jennifer speak first, and then introduce the rest of the attendings and our PA, Kate. Go ahead.
All right, can everyone see my screen? Yeah. Okay, great. Okay, so yeah, I'm here today to introduce our Rhode Island site. With me, I have Dr. Grobleski, who's our site coordinator, me, Dr. Taro, and Kate, our head chief PA. Oh no, hang on. Okay, and so basically Dr. Grobleski, if you're here, you can say hi. There you are.
Hi, everybody. Welcome.
So he is one of the pediatric otolaryngologists at this site. He is our site coordinator. And then Kate, would you like to say hello as well?
Hi, I'm Kate.
Perfect, thanks. So she's our chief PA, and she really just holds everything together. She's like just completely essential to our team. And then we have Dr. Taro, who is a general otolaryngologist, but focuses a lot on head and neck procedures. Dr. Taro, would you like to say hi? Well,
hello there.
Oh, there we go. Okay, great.
This is my background. It's better than Dr. Tracy's.
Oh, wow.
You see that?
It's way better than this office as well. Let's see. I'm on call, so here I am. So
I'm not on call, John. I can come by later. It's a 1-hour drive.
Okay, so just a little bit about Providence. So basically from Boston, it's roughly a 1-hour drive. 45 minutes or so, depending on the hours that you're driving. That may seem like a long time, but it actually goes pretty fast. And we do have an apartment that's provided up in Providence for those of us who would prefer to just stay, during the week in Providence. I personally drive back to Boston just because I like sleeping in my own bed. So it's very doable. And then why we come up here, we're basically the ENT department for Brown. So we work with the Brown medical students and the PA students. Brown happens to have basically every other department except for ENT, and so now they have us. So that is why we are up here. And the hospitals that we cover, so we cover Rhode Island Hospital. It's the state's only level 1 trauma center. It's actually the 3rd largest hospital in New England. It's a teaching hospital for the Warren Alpert School of Medicine at Brown. It has 719 beds, so it's massive. And it also has the Anderson Emergency Center, which is a massive, just a huge emergency room. It's among the busiest in the country. They have pods A through E, which each have a lot of beds, like 20 beds, a 12-bed critical care bay, a psychiatric bay. It's extremely busy and robust. We also cover the Hasbro Children's Hospital, which is the only pediatric facility in the state. And we also cover the Women and Infants NICU. So it's consists of about 80 NICU beds. Actually, an interesting little stat that I found is that the babies born here represent about 73% of all of the babies that are born in Rhode Island every year. And recently it was one of the best children's hospitals in neonatology. So that's what we cover, and it's quite busy. We work with lots and lots of attendings here. They're all sort of listed here, and you can see that all aspects of otolaryngology are represented by our attendings. Briefly, you met Dr. Grobleski, who's, again, our site coordinator, a pediatric otolaryngologist, who is complemented well by Dr. Gibson, another pediatric otolaryngologist. There's also a 3rd pediatric ENT who's joining and will be, I think, actively starting up in the next month or 2. We have Dr. Burchard, who does a lot of our facial plastics, a whole host of general otolaryngologists listed here. Brian Duff is the otolaryngology chief and also a neurotologist. And we also have Dr. Papazian, who is also otology trained. Dr. Taro does a lot of our head and neck, and Dr. Ween, as mentioned in the Tufts PowerPoint, spends most of his time up in Rhode Island now, and he has brought a much needed aspect of head and neck training up to Rhode Island Hospital because there is a lot of cancer up in Rhode Island as well. Dr. Patel just joined us as well. He's a laryngologist. We work with Dr. Elson, which is another unique portion of this rotation. He is oral and maxillofacial surgery trained, and so we do most of our trauma cases with him, which is awesome to get another perspective on just the training that how people do trauma. Anything else to mention here? Dr. Vasquez, also awesome. He's rhinology and skull-base trained, so we operate with him. And okay, so there are lots and lots of attendings.
Everybody looks really young in those pictures. Bick is the only one who actually looks that age.
Dr. Patel looks like that too, I guess.
Yeah, Patel too, but everybody else is a lot older now.
Well, they've all aged like fine wine, so. Okay, so our inpatient team, we have a large inpatient team because it's a very, very busy service. And actually, I'm on call right now, and knock on wood, I haven't been called, so I'm getting lucky on borrowed time. So basically, we have 4 PAs, and another one will be joining us in the next 2 weeks. So Kate, as you met earlier, is our head chief official lead PA, and she's wonderful. We have Valentina, who covers overnight call Monday, Wednesday, Friday. And I'll discuss our call schedule here as well. Libby, who is with us 4 days a week. Hamna, oh no, I jinxed it. Page. Hamna, who was one of our inpatient PAs and now has moved more to telemedicine. Emily is joining us the next 2 weeks. And then at all times, there's a PGY2 resident, as well as either a PGY4 or 5 resident, who's like the acting chief. And then we also get the interns up here for, right now it's 1 month, but that may increase in the future. Also, at any one point, we also will have Brown medical students join us, usually 1 to 2, and we almost always have PA students joining us as well. And there's usually 2, sometimes 1, sometimes 3, it kind of varies. But we roll deep. We have a pretty big team up here. And every person is absolutely necessary because it's just there's a lot of volume up here. So generally our schedule, I'm just going to go through an average week with you guys. Monday morning starts a little bit earlier, because we, actually I miswrote that. So we will round a little bit earlier, and then we have head and neck tumor board twice per month. That starts at 7 a.m., not 6. And that incorporates medical oncology, radiation oncology, radiology, pathology, head and neck, surgical oncology. And so I just put some of the people here that are also, participate and that we work closely with for our head and neck tumor board. And then we also go to the OR on that day. The OR is pretty much every day. Tuesday and Thursday are a little bit different. So Tuesday and Thursday we have afternoon clinic. So on Tuesday it's an adult clinic, and on Thursday it's a pediatric clinic, and it is a resident run clinic. It is supervised by a rotating schedule of attendings. In the morning, Dr. Ween has a head and neck cancer clinic. And we also have OR cases going, and we're also on trauma coverage on Tuesday and Thursdays. And trauma coverage is very busy in Rhode Island. I think we get a lot of our trauma experience up here. And so we split our trauma call with plastics. So basically we take Tuesday, Thursdays, and 1 Saturday per month. And then thankfully they take everything else, which is very nice. And then Wednesday, we also are in the operating room. And then in the afternoon, just as I sort of mentioned with the other presentation, we have our afternoon didactics. So, the residents at least will kind of cut out around noon or 1 to make those didactics because they are considered mandatory. And then Friday, more OR, but no clinics or anything. So, briefly our takeaway message is it's a very busy rotation with lots and lots of autonomy. We have all the surgical subspecialties represented at this rotation. We do kind of consider our home away from home. And like I mentioned earlier, some of us will stay in Providence, some of us will come back to Boston, and both are totally reasonable options in terms of just travel time. We cover a huge area with these hospitals, so all of Rhode Island. We get people from southern Massachusetts, Connecticut, sometimes New Hampshire, just kind of everywhere. And again, lots and lots of trauma. Very briefly, I wanted to just cover a couple just interesting cases that we had recently, just to kind of give you a taste of what's sort of going on up here. We get lots and lots of pathology. This is a guy that was actually just discharged yesterday, who presented with 2 days of sore throat, and not your typical sore throat. He had this huge defect in his pharyngeal wall, which, surprise. So, we kind of assumed, this is not the best picture, but thought, oh no, it was necrotizing fasciitis. And it kind of looked like that initially, but he's actually doing great. And so you can see, here's his tongue base over here, and the lateral wall here is just all necrotic and dusky. And so kind of just interesting, strange pathology that ends up here. Another interesting one that Dr. G did a couple of years ago, this NICU baby had airway obstruction, and they went to look in the mouth, and they saw this mass just kind of plopping around in the back. So we ran over there and intubated the patient, and then she went to the operating room, and this ended up being a dermoid was removed. So it might be hard to kind of orient, but this middle picture, we have the mouth gag in place, tongue kind of being depressed down, and this is the mass that's being kind of pulled up. So weird stuff. Lots of infections, lots of cancer, like I mentioned before. This on this left side is a guy who came in just into the emergency room with this massive cancer, and that is not uncommon in Rhode Island for some reason. It just they show up with these massive neck masses, and this other guy, which it's probably also cancer, but massive infection, and ended up draining, I think it amounted to 125 cc's from this neck mass. Just wild, wild stuff. Lots and lots of trauma, lots of lacerations, lots of complex lacerations, lots of facial fractures. Sorry if it's kind of, I don't know. And then this case I wanted to just show real quick. This one was when Dr. Dogger was at Rhode Island. You can see this poor man with this massive hole through his head and neck. And you can see additional photos of it going through his skull, through his brain. And then this kind of just fun video to watch, basically. The removal, just crazy. Ugh. Thankfully, no bleeding, though. We can pause that. And so that's basically all I had. So I wanted to open it up to Dr. Taro, Dr. G, and Kate. Add in anything else you want, and we'll open it up to questions.
Jenny, thanks so much. Can you hear me okay? I'm outside, so there might be a little wind, but hopefully you can hear me. Good. Well, welcome everybody, and I agree with everybody else's sentiments. We wish we could meet you in person, and hopefully we will have that opportunity at some point. I think Jenny touched upon everything. I would just highlight a few things. First of all, many, many years ago, Brown actually had its own residency program, and today, Brown has basically residency in all specialties other than ear, nose, and throat. So we've really been so happy and grateful that we have the relationship with the Tufts ENT residency program that we do. And I think because of that situation in terms of our academic center, our residents really feel part of the Brown program too. And I know our medical students here at Brown really appreciate the mentorship and getting the opportunities to work with the Tufts residents on a regular basis. So we've really, over the last 10 years, seen a significant increase in the number of students at Brown who are interested in ENT, and a lot of that is testament to our residents in the interactions that they have. Just to quickly touch base on Providence, I think Jenny mentioned it a little bit earlier, or Becky did too, but it's a cool medium-sized city, and it's a nice little break from Boston. We're not the size of Boston, but we definitely punch above our weight in terms of restaurants, and there's a lot of cool stuff to do here too. Obviously, we're known as the Ocean State, and for the residents who spend more time down here, there's a lot to explore, from Newport to the beaches to just the food scene in downtown Providence. So it's a really cool place, and some of the residents end up staying here even when they're not on call, but when they are on call, they're kind of in a great area that's less than 10 minutes from the hospital. It's got a bunch of restaurants on the same street, so they can walk down the street and get some good food and be close to the hospital. In terms of the rotations, I wanted to point out a couple things. You know, I think Jenny, again, covered everything, but one thing that's kind of unique is the opportunity to be a chief resident when you're a PGY4. And I think that's always a somewhat hard transition actually for our PGY4 residents, but it's a really important one. And I think it prepares them very well for the PGY5 year, in which is the traditional, you know, chief resident year at most programs. So you're really getting 3 months during your 4-year of truly running a service. And I think it's a really good couple months of experience, and our residents grow a lot during those 3 months. They really start to see what is needed to be a leader, and it helps them prepare for the chief residency year. The other thing to highlight too is the resident clinic, which is a really wonderful thing. I think, you know, it's busy at times, but the residents really get opportunities to see patients on their own in an outpatient setting. And I think that's unique. Obviously, anywhere you get opportunities to see the patients who are inpatient on your own, but in this situation, you know, we allow them to first start and see the patients. And really, a lot of our patients think of the residents as their doctor, and we're just kind of the backup support staff. And that's a nice feeling and an opportunity for our residents. Sometimes you end up seeing them over the years too, through head and neck cancer clinic, for example. So those are a few things that I wanted to point out, but I would definitely open up the floor to Dr. Taro and Kate as well.
So I might add, you know, the picture of the people that are at Rhode Island Hospital, that's almost a picture of all the practicing otolaryngologists in Rhode Island. And Rhode Island itself has a population of about 1.1 million people, but our coverage area extends into Fall River and New Bedford, Massachusetts, into Connecticut and southern Massachusetts as well. So our catchment area is well over 1.5, almost 2 million people. So we're all very, very busy, and it's a great experience for the residents. They get a lot of autonomy. They can choose the cases they want to participate in. For me personally, it's a really collaborative environment. We have a great relationship and rapport among all of the practicing otolaryngologists in the state, and I think that's a great opportunity for the residents.
Kate, anything you'd like to add?
Can you hear me?
Yes.
Oh, okay. Hi, I'm Kate. I mean, I agree with everything they both said. It's great working with residents. Providence is fun. We have a good relationship with the attendings and with each other, and it's just, we're helping each other, learning from each other. I mean, I've learned more from the residents because I'm with them, usually more than the attendings since I've, you know, started as a PA here. So it's a great time. We look forward to having you.
I would say too that the residents know that they can pick up the phone and call any of the attendings at any hour of the day, whether or not they're on call, and find help when they need it.
And really quickly, any questions from any of the students on? Okay, great.
Thank you guys, really appreciate you. We're gonna get a little break, and then we're gonna do our Brockton presentation. Give us a couple minutes to get set up. Thank you all. All right, guys, I'm going to share my screen. Again, my name is Sammy Nassif. I'm one of the PGY force. I'm currently in the Brockton rotation. So I have a little slideshow. One sec. You guys see my screen?
Yep.
Great. So our Brockton rotations is a 3-month rotation in our 4th year and a 3-month rotation in our 5th year. It's in this private practice group called ENT specialists. They're the largest private practice group in Massachusetts. They cover 5 hospitals throughout the South Shore area. You can see a couple of the cities include Taunton, Brockton, Norwood, and Milford. They do a lot of the aspects of ENT, including subspecialty exposure of endocrine surgery, sinus and allergy, sleep medicine, plastic surgery, and head and neck oncology surgery. They have multiple faculty. Dr. Dagger is our site director, and Dr. Shah is our medical student director. They're both here today. There's other faculty as well, many of them who were former Tufts residents. Dr. Degra, Dr. Brian, Dr. Pradhan, Dr. Steiner, and Dr. Russell. Some key things that I want to highlight about this rotation is that this is our primary exposure for basic thyroid and parathyroid pathology. We also get a unique experience in that we get to see in-office balloon dilations and sinus procedure in awake patients, something that's not commonly done, but it's good to know and see how it's done, how patients do, and the general setup of how to get this done in a private practice. We also get to do a lot of ultrasound-guided fine needle aspirations, and it's very helpful also for localization of parathyroid adenomas preoperatively. It's a very nice experience for that. In terms of what we are responsible for, we usually cover key indicator cases when they request a resident. We also cover the inpatient and emergency department consults from 7 a.m. to 5 p.m. in these hospitals. Call is a home call. We talked about it's every other weekend. We usually don't cover weekday nights. So it's an interesting experience when we're on call. On the weekends, we always have an attending who's a backup to us for anything that we need. Something also I want to talk about is our international experience. We did talk about our endocrine surgery experience with Dr. Dingra. He has a yearly mission trip to Gidra Hospital in Rwanda. In that area, like Jenny talked about, we treat patients with very large multinodular goiters. We also do portable ultrasound evaluations. I have some pictures that Aaron Hazer, our prior chief from 2018, gave to me. Is open to 1 to 2 residents per year. Unfortunately, due to the COVID pandemic, this was canceled. But here's some images that you can see. Very nice operative theater setup, even resource limited setting, which is nice. We have work with Dr. Dingra, who's our attending here. Picture this is Aaron. And then you get these really large goiters. I mean, massive size. You can see the hand for scale. It's a great operative experience. Here's another image of the goiter. That is the whole scalpel, and then it's almost bigger than the scalpel. And these are cases that they do almost 40 to 50 of these in a week. It's a very busy experience, and they established a base in a teaching hospital of Gidwe, where these patients can then followed long term. So there is continuity of care, even though we just go there for a week or two. There's at least someone that can see the patient for long-term care as well. That's all I have. With that in mind, I'm going to open the floor to Dr. Dagger and Dr. Shah.
Sammy, thanks. I think you summarized the rotation very well. I don't have anything to add. I don't know if Amir has anything to add.
I would just say, as a former resident, this rotation it's a really interesting experience because it's not many programs will allow you to see private practice and kind of what you would do outside of an academic setting and what kind of cases you would do. Our practice is a very robust practice, so we do a lot of variety, and we practice the scope of ENT, from head and neck to otology to laryngology. Everyone is a consummate generalist. So from that standpoint, it's a great experience. As Sammy mentioned, you cover the consults during the day, and it's interesting to kind of learn how to manage patients out in the community. And basically you're running your own service there, and the consults are your responsibility, and a lot of times the management is how you want to do it. You obviously always have an attending with you, but it's a good time to start feeling like an attending, because you get to make the calls, and you're talking directly to the attendings in the community who are consulting you. So from that standpoint, it's a real great real life experience. And just like every other rotation at Tufts or Rhode Island, all the attendings are love having residents and students and teaching. So same deal like Dr. Taro mentioned, you can call any attending at any time for help. And I think the residents find it a very valuable operative experience, especially for soft tissue.
Thank you, Amir. I would totally agree with that. I think I've only been here for a month, and so far it's been an invaluable operative experience. I've done more than 15 endocrine surgery cases. More than half of those I would say I've been resident surgeon already. The attendings are phenomenal. They really want you to learn. They want you to develop your own operative judgment and skills. And it truly has been a great experience. I'm really happy that not only do I get to do this now as a PU core, but once I do the other rotations in my 4th year, I get to come back with even more skills and get another crack at it again, get to learn more. And the more you know, the more you learn. So it'll be a different experience in the next year when I'm a chief resident, being with them and learning a little bit more nuance about how they do things and what are some different ways to treat the pathology that we see at Tufts, that we see at Rhode Island Hospital. I do want to show you guys a picture of all the attendings. I just found it here on the web. 1 second. This is the entire group. Just to put some faces. This is Dr. Pradhan, Dr. Dagger you saw already, Dr. Russell, who's a recent BMC graduate, Dr. O'Brien, Dr. Bayani, who's no longer practicing, but is the general practice president and lead manager. This is Dr. Shu, who was a resident almost 20 years ago, Dr. Slider, and then this is Dr. Tingra, who's the attending that does the treatment, the traveling to Rwanda, and Dr. Shaw, who you just saw here. Fantastic group, and we're very lucky to have them as part of our residency. Any questions, guys? All right. With that in mind, we'll get a little break, and then we'll next do our Boston Children's experience. Give us a couple minutes to get set up. Thank you.
Sammy, I'm just going to go ahead and share my screen.
Go ahead, Chris. Thank you. I think we can go ahead, Chris. Just keep going, get people out here.
Sure. Guess I'll just go through it.
One sec, Chris, we do have a question.
Sure. Go ahead.
I'm gonna read the question. This is from.
I mean, I can answer them in the chat if you want, or we can.
Go ahead.
Go ahead, Jenny. You wanna answer the question?
Okay, I guess I'll do it out loud. Sure. Okay. So, question: what do you mean by some residents choose to stay in Rhode Island during their rotation? Are they put up in a living situation somewhere? Yes. We have an apartment in Providence that's provided by the department, and it's like a 5-minute drive from the hospital. And so it has 3 bedrooms, living room, kitchen, I don't know, little dining area. So if you know, some people choose to stay there during the duration of their rotation. Other people choose to, I don't know if you can hear me about this. Other people choose to drive back to Boston. So, yep, we do have a place there. And Sarita, how do you think the department residency will change over the next 5 years? Any changes that are planned to be implemented in the department?
I can take that one, Jenny.
Great.
We have newly expanded in terms of the Tufts faculty over the past year. I can come get. We have some recent change that is now just translating into increased volume for residents and expanded experience in terms of the types of cases that they're doing. One example being transoral robotic surgery experience that Dr. Tracy will bring to the department, amongst others. The Rhode Island rotation, as was referred to several times, it's always been busy. It is getting busier. The addition of Dr. Ween down there doing a lot more operative head and neck than had been done there previously is giving us serious consideration for trying to expand the team down there. And so that's something we're looking at, which may require expansion potentially of the program. That's not something that's been laid out definitively yet, but it definitely has a huge amount of volume, both clinically and operatively, and that's something that we're looking to use to the advantage of our resident education. It may also even involve recruiting additional head and neck faculty if that kind of volume and trend continues. So these are areas that we're thrilled to see an expansion in our department, opportunities to increase resident experience, both in terms of numbers as well as breadth of experience. In terms of the mentoring, we do not have a formal mentoring program in place. Because we are small and all of our faculty really have a very open door policy in terms of being accessible to residents, it's been successful in our program for folks to seek out those they gravitate most towards in terms of either clinical interest or personality type. That we have not at this time instituted a formal mentoring program, but certainly those types of mentorship relationships develop from PGY 1 year onwards, depending on residents' interests.
I guess the only thing I would add to that is for, every year when we have to do our grand rounds presentation, or, you're supposed to kind of pair up a little bit or have like a faculty like mentor to kind of go through that presentation with, as well as like NEOS presentations. So, for smaller, I guess, like projects that we have to do throughout residency, we do kind of have like a formal mentor for that, but there's not a mentor that's assigned to you. Because we're so small, they kind of just happen.
So the last question, Alyssa Calder is asking, what do you like the most about having the different rotation sites? What do you think that having a private practice during your residency experience brings to your learning? I think, at least I'll answer your second question first. Having a private practice, I think, is key. We, half of all otolaryngologists in the country do private practice. And the environment of a private practice is very different than that of an academic medical center. And for us as residents to be able to choose correctly what we want in our future, both our practice, our lifestyle, and our interests, it's important that we know how private practice works, both in terms of clinic visits, organization structure, operative experiences, how covering other hospitals work, because we get a very select view of what being an otolaryngologist is in America, only in an academic center, and then we're asked to make a decision about you would do a fellowship or not, where do you go to practice, and I think having this 6 months truly gives you a taste of what could be you in the future, and yeah, I think it's invaluable and something that every program should have, in my opinion. And jumping on that, you know, having different sites ensures that you see not only a great variety of pathology, but also a great, you know, see different ways that problems are solved. You know, the beauty about medicine is that we're not cookie cutter and that every problem is an algorithm that you follow. There's many different ways to approach a problem, and you need to have all these different ways to fix problems for patients in your armamentarium to offer comprehensive care for your patients. Because sometimes an approach may not be available at the institution that you are. Sometimes an approach may not be able to be done because of the patient and their pathology itself. So I think having different sites allows you to be a comprehensive ENT.
And all the sites are so different. You're about to learn about Boston Children's, but they all truly offer a very different sort of experience, you know, where Tufts, you have a lot of, you know, like attending oversight and help, and, you know, you have like the really complex cases, the free flaps, and, you know, Rhode Island, you're getting all these sorts of different pathologies thrown at you, and, you know, you really get to practice your autonomy and managing how all these patients that you want. You have the resident clinic. You'll hear about Children's now. And you know, so it's just, you get totally different experiences at all of these places. And I think each of them are valuable and important. So Sarita, let's answer your next question after this Children's presentation. And anyone else who thinks of something, please write them in and we'll answer.
Great, thank you, Jenny. Hi, Chris. We're gonna start with the Boston Children's presentation. We're gonna have Chris Chumrick, who's our PGY3 currently there, as well as Dr. Jisoo Lee, who's our site director.
Hi, good afternoon, everyone. My name is Chris Shumrick, currently one of the PGY3s. As Sammy said, I'm currently rotating at Boston Children's Hospital. It's one of the first rotations we start off with during our PGY3 year. So it'll be a brief presentation, then I'll let Dr. Lee take over from an attending perspective. So is my screen up?
Yeah, we can see your screen.
Okay, I'll just keep it in this mode. We don't need to do the slideshow. So Boston Children's is, you know, obviously quite the impressive institution. It's annually ranked as one of the top children's hospital in the country, and I think that says a lot about the environment that you get there, the culture there. A few points about it: it's a metropolitan tertiary care referral center. It's only peds. It's a level 1 trauma center. It's got 395 beds. It's the pediatric teaching hospital for the Harvard Medical School. And, you know, we as PGY3s there, we get to rotate with the Boston Medical Center residents, as well as the Mass Ioneer residents. Which that's always great because you get to meet new people from new programs. And in my experience, the collaboration with the other residents has been great. So I've actually, you know, gained some friends through rotating through here. It's a very busy center, and I don't even think I've gotten that full experience yet because as post-COVID era, the caseload isn't as heavy as it's been in the past, but it's still even now busy. So I can't imagine what it is when it's like full strength. But here's a list of the attendings there. As you can see, there's a wide variety from wide areas around the country. from many different institutions, which I think is important because you get to see how people practice, and you get a lot of different techniques, different ways of thinking. And I've already seen that just being there 1 month. And I've already worked with the majority of these attendings in the operating room. From the resident perspective, what we're responsible for as residents there is pretty much during the day is just the operating rooms. We do very little floor management during the day. The call schedule is we do one in-house call, 24-hour call every 3 days, and we split that with the Boston Medical Center residents as well as the Mass Eye and Ear residents. Which is not, the post-call days are quite nice. We actually always rave about that. So at Boston Children's, we get a wide exposure to complex pediatric patients from all over the world. Given how renowned it is as a children's hospital, you'll see patients from multiple countries come here and all over the country come here just to get care for their child. So there's a high level of trust there from the patients and parents that they'll get the best care there. So they do have fellows, the ENT department there. There's 3 of them, and that's an interesting experience that we get as residents. We don't get that experience at Tufts, so it is nice to see how interacting with fellows is. In my experience, it's essentially like, they're, they were 1 year ago chief residents, and so a lot of them, have that kind of camaraderie for the residents, and they have your back. They always want to help you out. So that's my experience with them so far. There's weekly fellow-run conferences with exposure to the Pediatric Tumor Board, radiology rounds, and other pediatric multidisciplinary conferences. So it's a robust academic experience, and it's nice. We do have to commute. It's it's maybe about 10 minutes from Boston downtown proper, so not bad at all. And we get a nice little monthly allowance for food, and given the wide breadth of the attendings that we have here, as well as the resources that Boston Children's has, there's so many opportunities for research projects and other opportunities in that realm. Just in the 3 months that we get there. And it doesn't just stop at that 3 months. From what I understand is that if you are interested in research, you continue to do it your last 2 years of residency as well. That we're not just cutting off all connections after we're done with those 3 months. So, and from what I've heard, the attendings are very receptive to any ideas, and so I think all around it's a brief stay there. It's 3 months, but I think it's an important addition to our residency experience. So with all that said, I'll hand it over to Dr. Lee from the attending perspective and see if he has any added insight.
Hi, everybody. Can you guys hear me okay?
Yes.
Great. Thank you for inviting me and letting me participate in this. It's a unique exercise to do given this whole COVID situation. But I'm happy to talk a little bit more about Children's. So as Chris just mentioned, Children's is a unique place. And I think I like to describe the hospital itself as an open fire hydrant. And it's a proverbial fire hydrant where there's so much stuff going on, just patient-wise, that your job as a resident is to literally stick out your tongue and take a couple of steps from time to time and learn as much as you can. You will see pathology there every day that you will never ever see again. I think for your entire residency rotation there for 3 months, you may not encounter a single normal child. And I think that's the beauty. What Tufts uniquely has in general is a very robust pediatric experience throughout all of their rotations. They have a ton of peds down at Rhode Island. They've got a great pediatric service at their main campus at Tufts, at Floating Children's and Floating Hospital. And so I think the three pediatric experiences are all different, but they really complement each other. What Dr. Schumer, what Chris just mentioned about the 1 in 3 call right now will be the case for another year, but the next year. So for those of you coming in, that will change. We are in the process of obtaining more residents. So when you're there will be either 4 or 5 residents simultaneously. And what that does, it decreases the amount of call load that each individual has, but that actually will allow the residents to get a better experience outside of the inpatient service, more experience in clinic. We actually have many multidisciplinary pediatric subspecialty clinics, which unfortunately the residents don't really have much of an opportunity right now because they're so busy either in the OR or in the inpatient service. So we're hoping that it'll be in 1 year we'll have a 4th resident, in 2 years we'll have 5. That experience actually will be much better for everybody involved. The rotation is a inpatient-based service, so there are 3 pediatric oral fellows, otolaryngology fellows. There are currently 3 residents. There are 2 in-house PAs, and these PAs they manage all the floor work, see all the consults during the day, which allows the residents to spend all their time in the OR, learning how to operate. And then in the evenings, there's a handoff, and the residents take call. Because of the critical airway situation of children, there's so many sick kids. The hospital has mandated that an otolaryngology representative stay in-house every night. So the residents are in-house, which then gives you the day off subsequently. It's a phenomenal place to work. From my experience and as an attending, every single day encountering patients, it's like trying to solve a mystery. We see patients every single day that I have no idea what's going on. New genetic mutations, manifestations of a disease process that has never been seen before. I mean, what comes in through the door is just astounding. And so oftentimes we don't know what to do because we've never ever seen it before. And so my job and the job of the fellows and the residents are really to try to figure out the disease process and how to best manage these kids. And I think that's where you learn a lot of clinical skills. And you learn a lot of management skills because it's a busy place. The best part about the whole rotation, I think, is the fact that you get to rotate with your counterparts from the other programs. I know even now there are many friendships that have been formed at the children's rotation, and even decades out, I hear about attendings whose best friends or and best colleagues in this area are from those from the other programs that they rotated with while at children's. Each facility, each program has different strengths, different weaknesses, and I think you learn a lot from each other. So I think from my perspective, that's one of the best parts of the rotation. I guess that's it in a nutshell. Chris, did you have anything else you want me to add?
No, I think that pretty much sums it up very well.
Questions from all the participants?
I believe we really appreciate you coming in. This is great. This was one of my great rotations from last year for myself, and we thank you for coming. Again, guys, if you have any questions, please feel free to put them in the chat box. We can answer them as we go, or we can answer them later on our Q&A session. We have 2 questions here that we can probably tackle before the research section. Julia, you want to?
So one question was about after fellowships, the proportion of folks who go on to academic careers versus subspecialty practice. And it's been about 50-50 over the past 7 years in terms of the split. In terms of the level of autonomy, it varies by multiple different factors, including individual attending, case, resident level. In general, that Tufts has a more hands-on involvement by attendings as compared to Rhode Island. but I still feel that we provide appropriate levels of graduated autonomy by experience. And the nice thing is that we do get face time with residents from early on. So it's not like I'm doing a neck dissection with a PGY5 that I've never operated with before. So that familiarity in a small program allows you to really individualize your surgical mentoring and guidance to each resident.
Great, thank you, Dr. O'Leary. We are scheduled to start our next session 2:15. So a couple minutes and we'll be ready. Thank you, everybody. All right, we have some more questions about Boston Children's, I believe. First, we'll do the first one. You mentioned minimal clinic involvement in Children's. As a resident, what is the level of involvement in clinic, specifically in Tufts and in Rhode Island? Becky, do you want to tackle that?
Sure, I can tackle that. So at Tufts, we assist in our attendings clinics. We don't have a separate resident clinic. And I would say that you do a little more of this as a junior resident and less as a senior resident, maybe 1 or 2 days a week as a junior resident, and then sort of infrequently as a senior resident. But there's always an opportunity to come back and join your attending to see post-op patients, to help work up difficult head and neck cancer patients. So I think it's kind of up to the residents at Tufts, but it should be clear that we're helping with our attendings clinics. And then at Rhode Island Hospital, it's kind of neat. We have our own resident clinic in which we see the patients on our own, and then there's an attending who precepts the clinic. So they will then come join us and see the patients together and formulate a plan. But it just makes it nice. I feel a little more like the patients are my own at Rhode Island because we've seen them pre-op and then we'll see them post-op. So we have that contrast down there. But yeah, I think it's an appropriate level of clinic, less as you go along in the years.
I want to answer one more question before we start the research portion. This is a question by Alyssa Calder. Do the residents have the opportunity to be heavily involved in the OR, given that Boston Children's Hospital also has fellows? Dr. Lee, are you still available? Maybe you can.
Absolutely.
Question, yeah.
Yeah, so traditionally, I mean, historically, I think that's really been fellow dependent. And also the fact that a lot of the residents there are junior level residents. And so in general, there used to be this trend of having the junior residents operate on separate sets of cases than the fellows. Now, there's usually anywhere from 4 to 6 rooms, operating rooms, that are otolaryngology rooms going on at any given time. So there's actually a lot of stuff going on. What's changed over the past few years, and this is going to become a much more established thing, is that we've been really trying to collaborate, have a collaboration between the fellows and the residents. And one of the new fellow mandates that we have is to really train them how to be attendings, how to actually teach. And so it's been far better over the past few years about having fellows and residents work together. And what that means is that the residents, in addition to the bread and butter cases that they need to get good at, they've been having much better experience, I think, in a lot of the more complex cases, whether that's head and neck cases, airway cases, sinus cases, skull-based cases, etc. And so I think that's only going to get better over time. Alyssa, does that answer your question?
Yes, thank you.
Thank you, Dr. Lee. Thank you, Alyssa. Okay, we're going to move on to our next session, which is our research session. Dr. Scott has shared his slides, so I'll let him go right ahead.
Yeah, I'm just going to piggyback on what Jisoo was saying real quick as a transition. I was a Mass Eye and Ear resident, and so I did my 3 months at Boston Children's. And as he alluded to earlier, that is really where a lot, along with this other thing called NEOS, which is the New England Otolaryngology Society, is one of the main ways we interact with other residency programs. We share our didactics with Boston University, but there's a lot of cross-pollination that happens and a lot of friendships that are made. Dr. Vecchiotti was the fellow when I was the Mass Eye and Ear resident at Boston Children's. And he showed me a few things, and I still use them to this day. And then when I think about it, I have to reluctantly admit that I learned this from him when he was a fellow and I was the resident at Boston Children's. And so it is a nice, positive interaction. The other thing about Children's, and Jisoo is modest about it, but I mean, the place is unbelievable. I mean, it is the best children's hospital in the world. U.S. News and World Report, and all the NIH money that gets poured in there. Cardiac lesions that are not compatible with life, but are saved anyways because they can. And just absolute craziness that you will never see again, like he said. But also the entire, second floor is just interventional radiology for pediatrics. So it really is just, it's an experience. And I think for those who don't want to go into peds, you get just enough of it, and then you get it and you're ready to leave. But not in a bad way, but it's just like, it's an intense pediatric experience. But I think it really does to everybody who rotates through there, is that you will learn to be very comfortable seeing and taking care of even the sickest kid you could imagine. Hospital day 434 in the cardiac ICU. Like, how do you approach that baby? That congenital, conjoined twin, that you're rounding on. So, and once you can do that, you can handle anything that comes your way. And so I think it's a really great, heavy bat to swing. Finally, I pushed to do my children's rotation because I knew I wanted to do peds last, because I knew the fellows had to leave to take their boards at some point or they'd be studying. And so I got to do a lot of cases because the fellows were bored at that point and they were scared about passing their boards. So that was a great time to rotate at children's. All right, moving on to research. So I just wanted to highlight a few of the active projects that are going on right now, and then a few other things. We are a small program. We are not a research powerhouse. We do not fill every year with MD PhDs who have their own grants. That's not what this program is, and you guys know that. And if you are only figuring that out now, then you're not a very smart MD PhD, and you should have logged off a long time ago. But we do good research, and we do real research, and we have a shockingly good presence at the national meetings. And so we encourage our residents to, just like I was saying with Boston Children's, be very comfortable with research, with reading it, interpreting it, critiquing it, both through journal clubs, reviewing. We'll sometimes, say, hey, I got to review this paper. Why don't you take a first stab at it? Because you can learn a lot with that. Writing chapters, so that by the time you graduate, even if you don't think you're going to be a researcher or even want to write another paper ever again, that's because it's your choice, not because it's intimidating, not because you wouldn't know how to do it. We want everybody to graduate being very comfortable and choosing to do things, not being pigeonholed into them because they didn't get the experience. We're kind of fanatical about that, I think, in some ways. Everybody leaves being comfortable with the whole textbook of otolaryngology. So this is just a sample. I'm not going to read them because you never read your PowerPoint slides. That's the first lesson. But the point is that both, Tufts sites, Brockton, Boston Children's, Rhode Island, there's lots of different opportunities with lots of different attendings. These are just a few current projects going on right now in pediatrics and facial plastic surgery. There are more than these, but I was putting this together last night and I cut myself off at some point. Some of these will be summer projects that the med students are doing, and then maybe a resident will piggyback on that, show them how to do it, and pick up a little middle authorship with minimal work. Or the med student or the resident will be first author and take active role in it. But there's lots of different opportunities, both clinical and translational and basic science. So just some recently submitted abstracts. Most of these I think are what are getting submitted for the section meetings. Who knows if they're even going to happen in San Diego. Deadline's like Wednesday. I think they just extended it to Wednesday. That's a popular meeting because it's San Diego in January, and who doesn't want to go there? So hopefully we'll be able to do that. But these are some of recent cases that we're doing that, were being submitted.
this is just some of the publications, or rather national presentations in the last year, okay? So again, remember, it's not a big department, it's 2 residents, a year, but there's this page, and those are just the accepted, presented podiums and abstracts and posters. So we have a good footprint for the size of our residency. And we pay to have you register at the meeting and to fly out there, and there's dinner and we have a good time, but but people go and present and attend these meetings and get what's good to come out of it. Recently submitted manuscripts that are currently being reviewed right now. So this sort of gives you a snapshot of not just what's been submitted, but like what we're waiting to hear back at. So that means like at any given 1-month cycle, there's this many things that are kind of pending. And then peer-reviewed publications in the last 12 months, I think there's probably been about 20 or so, with a lot of, Dr. Harb is padding her CV for her facial plastics fellowship. So she's got a few of those. And many of these are, Sammy and I just had this accepted. Regan's a medical student, Ashley was a medical student, Leo went into general surgery, but we finished publishing that. Emily just matched in otolaryngology. So there's a lot of med student stuff on here too. Becky, Grace, who's one of our sub-Is. So Emily, so Michelle. So lots of good opportunities, and we try to have that culture available. There's a great opportunities for collaboration at Tufts. We are not, browbeating everybody to publish, but if it's something you're interested in, the opportunities are amazing. We have a very, very reputable School of Nutrition. I mean, if you listen to NPR, and any given week, there'll be somebody from the Tufts School of Nutrition talking about something. The School of Dental Medicine, veterinary medicine is thought of as being top 1 or 2 vet schools in the country. Our public health school is very well respected. And then in Rhode Island, there's Brown Med School, Warren Alpert Medical School at Brown. And of course, what was just being alluded to at Boston Children's, and the amazing opportunities there, both for clinical and basic science if you want it. Current collaborations that we have ongoing within the department. So these are active projects that are being written up right now or recently published with some of the collaborators we've had. And so, this will span, actually, University of Chicago should be on here too. But lots of Midwest touch points. Forsyth Institute is a pediatric dentistry basic science institute that's very well funded that we will collaborate with at times. Hopkins and others. One of the more famous and productive laboratories on the Tufts Chinatown campus is the Schwab Laboratory, which does basic science olfactory research. And they are churning out publications on stem cell and regeneration. And we've had a few residents do basic science, mouse work with them, histopathology work, tissue culture. And so there's lots of opportunity through them, and Dr. Rabiz has some collaborative work with them as well. I currently have it's not my grant, but I piggybacked off somebody else's grant, so it looks good on my CV, with the Forsyth Institute for cleft lip research, looking at hypertrophic scarring in cleft lip models with rabbits, and then also in kids. We have a prospective trial going on, clinical trial right now with our cleft lip patients. So again, lots of different opportunities for that. This was the last San Diego meeting, I actually didn't make it, but the army of students. In the middle is Nicole, who's actually our scribe, who was first author on one of her presentations as well. So we are very much encouraging everybody who's interested, no matter who they are. We grab people off the street to try to get them in and doing publications with us if necessary. Ramya was chaperoning the students, so thank you, Ramya, for doing that. All right, I'm going to mute, take any questions.
While we're waiting to see if anyone has questions, I'd just like to say that the collaboration with other departments and other schools has been beneficial in terms of resources like statisticians, and there's a lot of those resources available through the dental school, through medical oncology, through the Neely Cancer Center. So things that we don't have contained within our own department, we can access through collaborations with others, which has been very successful for a number of our resident research block projects.
Yeah, there's the CTSI, the Center for Center for Translational and Statistical Institute or something institute, that has office hours on Wednesdays where you basically can show up and some stats grad students sitting there waiting to crunch your numbers for you if you want, and critique your design and do a power calculation for you. There's a ton of resources out there to help out. And we are doing a REDCap study right now. I'm sure some of you have worked with REDCap, which allows us to do multi-institutional de-identified database work. And that is all paid for, done by through the CTSI. So yeah, there's a robust support network there within the medical school and within the institution.
Okay, thank you very much, Andrew. I don't see any new questions right now, so I'm going to move along to the next section about navigating the match. Certainly a unique year. I'm trying not to use the word unprecedented because that's like been used so much everywhere that it kind of makes me nauseous when I hear it, but it's a unique year. We've recognized that. I think you should all take some comfort in the fact that not doing the sub-Is, visiting sub-Is this year has two advantages. Number one, it levels the playing field for everybody. Number two, there are, when you think about it, those sub-Is are only a very small proportion of the programs you apply to overall. So although it is a tremendous amount of time and effort to participate in those sub-Is, it really is only a very small slice of the programs you ultimately apply to. So it feels like a big loss. It is a big loss in many ways, but there are many things about this match that are not different from other years. There was a program sponsored by the American Academy of Otolaryngology and the Otolaryngology Program Directors Organization. It was on Thursday evening. Some of you may have participated in that. So I'm going to mention a few highlights from that may be a little redundant for some folks, but I think they're very worth mentioning. You know, we don't expect to see 4 letters of recommendation from otolaryngologists from a variety of different programs as we would in a typical year. So look for people that know you well, that can write a strong letter for you, no matter what your experience has been. If it's been on another clinical rotation, if it's been a research mentor, and ask them if they feel they can write you a strong letter. Give them the opportunity to say no if they feel that they can't, because you really want to have good, strong letters in support of your application. Tell us in your personal statement if you don't have a home residency program. Highlight those things that may not be imminently evident as we review the other aspects of your application. Tell us about unique circumstances. Don't be worried if you came to otolaryngology late, but it might be something that you might want to mention in your personal statement. That's a chance to tell us unique factors about you that might not come through in your CV and other aspects of the application. You can feel free to do an individualized paragraph at the end of your personal statement for an individual program. You do not have to. I think there are a few programs, a few residencies out there that still mandate it, but most of us do not. So use it at your discretion. It can be helpful. It is not helpful if you just regurgitate information from the program's website, but if you have particular interest in terms of being in a geographic location or having family connections or any other reason that you'd be specifically interested in a program, that is a useful place to put that. In terms of step 2 scores, there is no expectation, certainly on our part and most programs' part, that you will have step 2 scores by the time you apply. If you have a lower step 1 score and you take your step 2 and get a higher score, that can be an advantage to your application. If it's lower, that certainly is not an advantage, so keep that in mind. If you have a strong step 1 score, there is not a reason that you have to have step 2 done by the time we view your applications, which is October 21st. As I said at the beginning, we are not correlating your participation in this virtual sub-I with likelihood of getting an interview with us. We appreciate your interest, but we understand that this is a unique year. We're all navigating this the best we can, and we do not want you to feel pressure that that is going to somehow be a signal of interest in our program necessarily. Other ways that you can express interest to programs in the absence of the sub-Is, the visiting sub-Is. Obviously, you can participate in these types of town halls or Zoom meetings. You can reach out to programs, but I would be selective about it and wait until the time when we're actually reviewing applications, which will be late October, early November. If you do it now, it will lose its impact by the time we're getting to actually see your application. And it will definitely lose your impact if you send an individual email to 30+ program directors. So be selective about it. There may be an additional new mechanism this year in order to express interest called signaling. That is still being evaluated, and if it comes into effect, you will definitely hear more about it. You may have heard some already. Be honest about any slowdowns in your research due to COVID. We are all in the same predicament, and we understand if things couldn't get completed because of disruptions due to the pandemic. Also, include everything that was accepted for meetings that got canceled due to the pandemic. You deserve credit for that work, and you should definitely include that. And finally, a helpful mechanism can be to reach out to a program coordinator to be put in touch with a graduate of a recent graduate of a residency program or a current resident to get a little more personal communication and connection and a feel for what the learning environment and culture is like in a residency program. So these are additional things that you can do to just get a sense of different programs and really make your research into your application process as comprehensive as possible. We wish you all the very best of luck. We understand it's a stressful time under the best of circumstances, and we're happy to provide any additional information that you need. So, I don't see any other questions in the chat, but oh, here we go, we just got one. Do you think the residency interview format will change? We will be doing virtual interviews, everybody will. We are not planning to interview more applicants than typical. Our interview format, we have a committee formed to sort of discuss how it's actually going to look, but there will not be as many sort of individual one-on-one interviews. That would just be too overwhelming over Zoom. So there may be sort of a lesser number of interviews with a larger number of interviewers per session, but we are still working on that and figuring out what we think will work best. If anyone else wants to chime in about navigating the match, they're welcome to do so while we see if there are any more questions.
No, and I wanted to say, your best advocates are your program director and your chair, so do ask their advice. If you want to reach out to us, Dr. O'Leary or I, or any of the faculty members, residents, we're more than happy to chat with you one-on-one, either by phone. And I don't mind saying that if you happen to be coming to Boston for a visit, we don't want you to travel so that you avoid getting infected, getting exposed. But if you are coming to Boston and you call us we can make some time to meet with you we'll keep physical distancing and so forth, or by phone or by Zoom, or, we're happy to answer more questions one-on-one if you need us to.
Hey, Miriam, can I add a comment?
Yep, go for it. Go for it, G.
I had the opportunity to actually interview remotely for the Beth Israel Deaconess Program. For those who don't know, they just were approved to start their own residency, but the approval occurred after the match last year. And so we interviewed for applicants remotely in April, and it took a little effort to get started, but to get it all organized. But once it did, it actually it went much better than I thought, I think, for the applicants as well as for us. And so for those all of you guys who are wondering what that's going to be like, it's surprisingly not as intimidating or formidable as you would think it would be. In many ways, I thought it might have made it easier because people were actually in their own environments at home or in their office or wherever they may be as we interviewed. So I think as Dr. Rabiz and Dr. O'Leary have kind of alluded, I think every program will have to kind of figure out how they're going to arrange that. But in general, I think it'll turn out okay.
Thanks very much, Jisoo. Our PGY5s have both done their fellowship interviews via Zoom. It was actually pretty cool because we had a long head neck case and Becky was able to do the first part, scrub out, do her interview, and pop back in for the end. So there are advantages to the Zoom format. So I'd like to just share my screen while we're finishing up here. Give you some more contact information. The chief residents have put their contact information in the chat function. But this is my email. Our program coordinator, Veronica, who's also on the Zoom today, this is her email and phone number. Please don't hesitate to reach out. And at the bottom here, I just put the website for the medical students section of our National Academy website, which will also be a helpful resource that you may or may not be aware of. But please don't hesitate to reach out. We know it is not easy trying to figure this all out at a distance. Oops, sorry.
It doesn't need to be any other question.
I don't see any other questions right now. So please, like I said, reach out if things come up later. We very much appreciate your participation, and a huge thank you to all of our residents, faculty, and one physician assistant who dedicated time to participate. Thank you very much.
And bravo, Sammy, for putting this together. Thank you for that.
Thank you.